The clinical presentation of migraine is diverse and can vary significantly between individuals, as well as between attacks experienced by the same person. Despite this variability, several key features are characteristic of migraine attacks. A typical migraine attack often progresses through a series of overlapping phases, including premonitory symptoms, sensory disturbances known as aura in some individuals, the headache itself, and a postdrome phase. The premonitory, or prodromal, phase can occur hours or even days before the onset of headache. Common symptoms during this phase include yawning, mood changes, sensitivity to light, neck pain, and fatigue. Some individuals may also experience increased thirst, frequent urination, and food cravings. It is important to note that patients may not recognize these symptoms as part of the migraine attack unless they are specifically asked about them. Certain triggers, such as specific foods, exposure to light, sound, and strong odors might actually represent early manifestations of the premonitory phase, reflecting underlying gastrointestinal and sensory sensitivities. These symptoms are likely related to activation of the hypothalamus. In approximately 1/3 of individuals experiencing migraines, an aura precedes or accompanies the headache. Aura consists of transient neurological symptoms that are focal in nature. The most common form of aura is visual, characterized by shimmering lights, zigzag patterns, blurred vision, or bright and dark spots within the visual field. These visual phenomena typically develop gradually over a period of 5 to 60 minutes. Additional aura symptoms may include sensory changes such as unilateral tingling sensations or numbness beginning in a limb or the face and progressing along the same side of the body. Some individuals may also experience speech or language disturbances, such as difficulty speaking or understanding language. Less frequently, aura can involve motor weakness, which is characteristic of hemiplegic migraine. Other possible symptoms include brainstem disturbances such as double vision, vertigo, ringing in the ears, hearing loss, or coordination problems. Retinal disturbances, leading to visual problems in one eye, can also occur. The evolution of aura symptoms generally occurs gradually over minutes, often involving a sequence of different neurological phenomena. The presence of positive phenomena such as visual bright lights or tingling sensations followed by negative phenomena like vision loss or numbness can help distinguish migraine aura from stroke or transient ischemic attack, which generally have a sudden onset and primarily negative features. The underlying mechanism responsible for aura is cortical spreading depression, a wave of altered nerve cell activity spreading across the brain cortex. The headache phase of a migraine is often characterized by throbbing or pulsating pain. However, it can also feel pressure-like or constant. Typically, the pain is located on one side of the head, though it can also affect both sides. Common areas affected include the front and sides of the head. The intensity of the pain usually ranges from moderate to severe, and it can significantly interfere with daily activities such as work or study. The headache may worsen with or lead to avoidance of routine physical activities like walking or climbing stairs. If untreated or not effectively managed, the headache usually lasts between 4 and 72 hours. It is often accompanied by additional symptoms such as nausea or vomiting, increased sensitivity to light, photophobia, and increased sensitivity to sound, phonophobia. Other associated symptoms may include sensitivity to smells, known as osmophobia, and cognitive dysfunction. Additionally, many individuals experience cutaneous allodynia, which is a condition where normal touch feels uncomfortable. Following the headache phase, a postdrome phase can occur, lasting for several hours. During this period, individuals often experience fatigue, mood changes, and neck pain. The exact cause of these postdrome symptoms is currently unknown. It is important to acknowledge that not all migraine attacks will exhibit all of these features. The specific combination and severity of symptoms can vary from person to person. The International Classification of Headache Disorders provides detailed criteria for diagnosing migraine with and without aura based on these clinical features. The diagnosis of migraine is primarily based on clinical evaluation, which involves taking a detailed patient history and performing a physical examination. Special attention is given to neurological signs and symptoms. Typically, Diagnostic testing such as neuroimaging is not necessary unless there are specific warning signs indicating a secondary headache disorder. A thorough and chronological description of the headache experience since its onset is essential. This includes details about how often the headaches occur, how long they last, their location, and their characteristics. The patient's history should also include any associated symptoms, such as nausea, vomiting, sensitivity to light, sound, or odors. It is crucial to inquire about factors that worsen or alleviate the headache, noting that movement often exacerbates migraines. For women, it is important to consider whether the headaches are related to their menstrual cycle, which can suggest a hormonal influence. A history of recurrent attacks that meet diagnostic criteria supports the diagnosis of migraine as a primary headache disorder. However, caution is advised when assessing a first-time presentation, as it may require further investigation. The first step in ruling out other causes of headache involves looking for warning signs or symptoms that might suggest an underlying medical condition. These red flags include an abrupt onset of headache, often described as a thunderclap, headache, or persistent neurological deficits that last for several hours or days, indicating possible alternative causes. Headaches beginning after the age of 50, or those associated with underlying health conditions such as cancer or immune system suppression, also warrant careful evaluation. Other concerning signs include headaches provoked by physical activity or changes in posture, the presence of fever or systemic illness, altered mental status, jaw pain related to blood flow issues, or signs of meningeal irritation. If any of these warning signs are observed, diagnostic tests such as neuroimaging should be considered. Conversely, such testing may not be necessary if the headache has a gradual onset, is transient, and exhibits typical migraine features. Once secondary causes are ruled out, the focus shifts to identifying the type of primary headache disorder based on the headache semiology. Migraine is broadly classified into migraine without aura and migraine with aura. According to the International Classification of Headache Disorders, 3rd edition, the diagnostic criteria for these conditions are as follows. Migraine without aura is characterized by at least 5 episodes that fulfill specific criteria. These episodes include a headache lasting between 4 to 72 hours if untreated or unsuccessfully treated. The headache must have at least 2 of the following characteristics: unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation by or avoidance of routine physical activities such as walking or climbing stairs. During a headache, at least one of the following symptoms should be present: nausea and/or vomiting, or increased sensitivity to light and sound, known as photophobia and phonophobia. The diagnosis should not be better explained by another disorder according to the latest classification of headache disorders. A migraine with aura, also known as a typical aura, is characterized by at least 2 episodes that fulfill specific clinical criteria. These criteria include the presence of at least 1 fully reversible aura symptom, which can be visual, sensory, speech and language, motor, brainstem, or retinal in nature. Visual symptoms may include flashing lights, zigzag lines, or scintillating scotoma. Sensory symptoms may involve tingling or numbness. Speech and language disturbances, such as dysphagia, are also common. Motor symptoms can include weakness, as seen in hemiplegic migraine cases. Brainstem symptoms might involve vertigo, tinnitus, or double vision, while retinal symptoms could include monocular visual disturbances experienced during retinal migraines. Furthermore, certain characteristics are essential in diagnosing this condition. For example, at least 1 aura symptom should spread gradually over 5 minutes or more, and 2 or more aura symptoms may occur successively. Each individual aura symptom typically lasts between 5 and 60 minutes. It is also important that at least 1 aura symptom be unilateral, affecting only one side of the body or vision, and that at least 1 symptom be a positive phenomenon, meaning it involves the addition of perceptual effects such as bright lights or tingling sensations. Usually, the aura is accompanied by a headache or occurs within 60 minutes after the headache begins. Lastly, for an accurate diagnosis, these symptoms should not be better explained by another diagnosis according to the criteria established in the International Classification of Headache Disorders, 3rd edition. It is essential to rule out secondary causes of headache before diagnosing a primary headache disorder. Features that may indicate a serious underlying condition include a thunderclap headache, which peaks instantly, as well as the presence of fever, new abnormal neurological findings such as focal deficits, altered mental status, or changes in cognitive function. Altered mentation, a new headache in individuals over 50 years of age, jaw claudication, and signs of meningeal irritation are also concerning. Patients exhibiting new abnormal neurological signs, experiencing a sudden onset severe headache, or being HIV positive with a new type of headache should undergo urgent non-contrast head computed tomography imaging. If the computed tomography scan is negative but the patient has a sudden onset of a severe headache, a lumbar puncture should be performed to rule out subarachnoid hemorrhage. However, the response of pain to treatment alone should not be used as the sole indicator to determine the underlying cause of an acute headache. Secondary causes of headache may include a variety of conditions such as infections of the central nervous system, intracranial tumors, strokes, trauma, intracranial masses, meningitis or encephalitis, bleeding within the brain, preeclampsia, thrombosis of the central veins, pituitary apoplexy, arterial dissection, Chiari malformation, cerebral aneurysm, carotid artery narrowing, disease of the vertebrobasilar arteries, and tumors like pheochromocytoma. There are no primary laboratories or imaging tests that are routinely recommended for diagnosing typical migraine. The diagnosis of migraine is mainly clinical, based on a detailed patient history and neurological examination aimed at identifying characteristic symptoms and excluding secondary causes of headache. Diagnostic testing, including neuroimaging and laboratory tests, is generally not necessary for patients whose headache presentation aligns with migraine and who do not exhibit any red flags, indicating an underlying secondary headache disorder. In fact, there is concern regarding the overuse of neuroimaging in patients with primary headaches, including migraines. However, in certain scenarios, further investigations such as imaging or laboratory tests may be considered to rule out secondary causes of headache. These situations typically involve the presence of red flags or atypical features. Neuroimaging, such as computed tomography scan or magnetic resonance imaging of the brain, may be considered if there is a new onset of headache, especially in individuals over the age of 50. It might also be warranted in cases of sudden and severe or thunderclap headache, abnormal neurological examination findings, or a pattern change or progression in the headache. Other indications include headache associated with fever, stiff neck, or signs of systemic illness, a history of cancer or immunosuppression, headaches provoked by physical activity or changes in posture, or persistent neurological symptoms such as prolonged aura or unresolved neurological deficits. Suspicion of structural brain lesions and cases of suspected migraine with brainstem aura, hemiplegic migraine, or retinal migraine are also reasons to consider further investigation to exclude secondary causes. Laboratory tests are not typically part of the routine diagnostic process for migraine. They may be ordered if the clinical picture suggests systemic illness or an underlying medical condition that may be causing the headache. Overall, the diagnosis of migraine remains a clinical one. Routine laboratory and imaging tests are not indicated unless there are atypical features or red flags suggesting a secondary headache disorder. The initial evaluation should focus on a comprehensive history and neurological examination to classify the headache type and rule out more serious conditions. Headache disorders can be broadly categorized into several types, with migraines being a prominent primary form that often requires emergency care. The International Headache Society classifies headaches into primary headaches, secondary headaches, and a third category that includes painful cranial neuropathies, facial pain, and other headache types. Primary headache disorders are those where the headache and associated features occur without any external cause. The most common types are migraines, tension-type headaches, and trigeminal autonomic cephalalgias. Migraine is a chronic neurological condition characterized by recurrent attacks of throbbing pain, often on one side of the head. It is the second most common cause of headache worldwide and the leading cause of disability in individuals under the age of 50. Approximately 15% of women and 6% of men experience migraines annually, with a global prevalence of around 11.7%. Attacks are usually accompanied by sensitivity to light, sound, and movement, as well as nausea and vomiting. These attacks typically proceed through 3 phases: premonitory, headache, and postdromal. Some individuals also experience a 4th phase called aura, which involves transient neurological symptoms. Features during the premonitory phase may include yawning, fatigue, mood changes, neck discomfort, and food cravings. Central sensitization in migraines is indicated by cutaneous allodynia. Migraine can present with or without aura. When aura is present, it involves transient neurological symptoms that usually precede or accompany the headache, with visual phenomena being the most common. Other types of aura include brainstem and retinal phenomena. In some cases feature hemiplegic migraine, whether familial or sporadic. Chronic migraine is characterized by headaches occurring on at least 15 days per month, with at least 8 of those days meeting migraine criteria, sustained over 3 months. The condition known as probable migraine is also recognized, and status migrainosus is a particularly severe and poorly understood complication. The development of migraine involves complex neural and vascular mechanisms. Serotonin plays a key mediating role. Evidence suggests that genetic mutations affecting ion channels can predispose individuals to migraine aura, particularly in familial hemiplegic migraine types. Functional neuroimaging indicates involvement of various brain regions, including the brainstem and posterior hypothalamus. To distinguish migraine from other headache types, factors such as younger age, absence of cerebrovascular risk factors, female sex, and a history of migraine are helpful, especially to differentiate it from stroke. Tension-type headaches are characterized by a chronic, bilateral head pain described as a tight, band-like discomfort. The pain typically develops gradually, fluctuates in severity, and can last for several days. They can be episodic or become chronic, occurring more than 15 days a month. Unlike migraine, tension-type headaches generally do not feature nausea, vomiting, sensitivity to light or sound, or throbbing pain. These headaches are often described as featureless, and their exact underlying mechanisms are not fully understood, but they are believed to involve a primary disorder of central nervous system pain modulation. Trigeminal autonomic cephalalgias are a group of primary headache disorders that include several specific conditions. These conditions consist of cluster headache, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing or other cranial autonomic symptoms, and hemicrania continua. These disorders are characterized by relatively short episodes of head pain that are associated with symptoms on one side of the head. Such symptoms include watering of the eye, redness of the eye, a sensation of fullness in the ear, or nasal congestion. The pain itself is usually severe and may occur multiple times throughout the day. Patients suffering from trigeminal autonomic cephalalgias are often misdiagnosed with sinus headache due to the presence of nasal congestion or rhinorrhea, and they are sometimes treated with decongestant medications, which are ineffective for these conditions. It is important to differentiate trigeminal autonomic cephalalgias from other types of short-lasting headaches that do not present with prominent cranial autonomic symptoms. Examples of such conditions include trigeminal neuralgia, primary stabbing headache, and hypnic headache. In addition, imaging of the pituitary gland and assessments of its function may be necessary because there is an increased incidence of these headaches in patients with pituitary tumors.